we were discussing the role of adjuvant therapy for esophageal cancer, and it's actually an interesting and evolving space now. As many will know, there were data presented at ESMO describing a fairly significant benefit to adjuvant nivolumab for esophageal cancer patients, and so we were talking primarily about not that, because I think those data are fairly impressive and should be convincing to most, but about the role of adjuvant cytotoxic chemotherapy. And it was an interesting debate because there really are two sides. I think there are those who will lean on some of the data around neoadjuvant therapy, and of course some of the data around the treatment of gastric cancer or gastroesophageal junction cancer, where there is good data for perioperative treatment, and say that supports adjuvant data in esophageal cancer patients who are high risk, who maybe have a larger number of lymph nodes positive, maybe did not have a particularly good response to neoadjuvant therapy. And there are others who are more strictly by the data type clinicians who will say, listen, there are no randomized studies for cytotoxic chemotherapy in the adjuvant setting that really support this. And so based on the fact that we know that giving additional treatment will expose patients to additional toxicity risks, I think we should really stick to the data that we do have for neoadjuvant treatment, of course, leaving aside immunotherapy. So we had, I think, a very interesting debate with two sides. I don't think I came away with a right answer, and I think that clinicians are forced to choose based upon the available data, and of course the individual patients and the particular risks associated with those patients and their disease.